Okay, thank you very much for this opportunity. It's a shame that we could not be in Addis in person for this meeting for reasons beyond our control. But we're also thankful to advancements in technology to make it possible for us to share these experiences online. So I'm going to be speaking on behalf of the Clinton Health Access Initiative to kind of talk a little bit on what Chai has been doing across the continent and particularly in Cameroon with regards to integrating HPV vaccination with adolescent health services. So it's a short presentation with the outline like you see. So we'll begin with a brief background. It's well known that cervical cancer is a public health problem worldwide, globally. I think in 2020 it was the fourth most common cancer amongst women worldwide. And interestingly, like you see on the map on your screen, the distribution of the burden of the disease is quite unequal across the globe, with the majority of cases and deaths registered in low and middle income countries. That's Asia, Sub-Saharan Africa, and South America, but particularly in Sub-Saharan Africa. So the high mortality and morbidity due to cervical cancer in these low and middle income countries could actually be reduced if concerted efforts are made around three key pillars, notably the vaccination of at least 90% of girls with the HPV vaccine before the age 15, screening women between the ages of 35 and 45, excuse me, with a high performance test, and of course providing to at least 90% of these screened women who screen positive with appropriate treatment for the disease. Now, interestingly, in low and middle income countries where the burden of the disease is highest, access to pillars 2 and 3, that's screening and treatment, is really very limited, which means vaccination, which is pillar 1, becomes a critical component to actually helping these countries curb the burden of cervical cancer. But evidence suggests that only about 1% of women in 1% of women targeted by HPV vaccination programs across the globe reside in low and middle income countries. And in fact, only about 2.7% of females aged 10 to 20 years in these settings have received the full course of the HPV vaccine as compared to almost 35% in high income settings. And the reason for this really low coverage of the HPV vaccine in low and middle income countries could be attributable to the fact that a lot of these countries find it difficult to implement a multi-dose vaccine program, and also due to the fact that the target population for the HPV vaccine is quite a new one compared to that of usual EPI vaccines, which is adolescents. And evidence from literature has shown that adolescents are quite a difficult group to reach with preventative health services. So to try to address the access to the HPV vaccine and of course raise coverage, integration of HPV vaccination with other health services has been the order of the day. Now, it's important to actually mention the fact that integrating vaccination services with other health and non-health services goes, way beyond the HPV vaccine. There's evidence of the use of, infant vaccination platforms to provide HIV services, to vitamin A supplementation, deworming, and many other services. And the importance of actually integrating HPV vaccination with other adolescent health services has been well established, and probably explains the reason why a lot of low and middle income countries have been using this option to raise HPV vaccination coverage in their settings. Just a few examples here. We have Rwanda, who delivered the HPV vaccine together with a booster dose of the measles and rubella vaccine. In Tanzania, there's a HIV plus program where health education, deworming, nutrition, and vision screening is combined with HPV vaccination. If you go to Uganda, the vaccine is delivered through schools on child health days and deworming, and also through the deworming program. Okay, sorry for that technical interruption. So I was saying the previous slide highlighted different examples of integration across different low and middle income countries. And I was also saying that with regards to integration and HPV vaccine introduction across Africa. So since 2017, China has actually supported introduction of the HPV vaccine in about 7 countries, leading to the aversion of almost 13,000 deaths per year combined in those countries. And in 3 countries, particularly, that's Cameroon, Kenya, and Lesotho, China is also exploring the possibility to, link HPV vaccination with adolescent services in order to improve on the access to the HPV vaccine and coverage. So from here henceforth, we'll be focusing particularly on Cameroon, kind of share the experiences we've had with regards to trying to strengthen the linkages between adolescent services and HPV vaccination in Cameroon. So before we go into details on the integration aspect in Cameroon, it will be good to have an overview of what HPV vaccination, the HPV vaccination levels are in Cameroon. So in Cameroon, HPV cervical cancer is the second most frequent cancer among women and even among women of reproductive age. So we have about 2,000, just slightly less than 2,800 new cases every year. And as you can see from there, a good proportion of those women actually end up losing their lives annually as well. So with this in mind, the Cameroonian government, alongside key partners, introduced the HPV vaccine to girls aged 9 in October 2020. When we fast track to June 2021, which is almost a year after the introduction took place, our coverage was still suboptimal, with less than 30% for HPV-1 and even less than 3% for HPV-2. So in order to identify the barriers that were limiting the uptake of the vaccine across the country, CHI actually supported the EPI to carry out a post-introduction assessment where 101 out of the 197 health districts in the country at the time were randomly selected, and a combination of text reviews, which entailed reviewing data from the DHIS2 platform and meeting reports and annual work plans on various immunization indicators, alongside key informed interviews of a combined 377 healthcare workers, health administrators, members from the education sector, and even from the community, in order to have a good idea on those different barriers to the HPV vaccine uptake in the country. So as key findings, we noticed that there was a limited engagement of stakeholders, notably the religious leaders. The deputy EPI manager just mentioned the role that they had to play with respect to the introduction of the HPV vaccine. So there was limited engagement of these stakeholders, which led to considerable hesitancy and poor buy-in. In fact, like we heard from the previous presentation, more than half of our health facilities in Cameroon are run by the private organizations or confessional bodies. But only about 4% of these private facilities provided the HPV vaccine, as compared to about 38% of public facilities, just highlighting the level of hesitancy that existed within that stakeholder group. In addition to that, we also discovered that healthcare worker knowledge on HPV in general and HPV vaccination wasn't good enough. Only about 23% of sampled healthcare workers had good knowledge on the subject. Furthermore, when the vaccine was introduced, the aim was to introduce it via a dual approach, that's in schools and also through health facilities. But the limited engagement of education stakeholders and other key stakeholders that operate educational facilities, such as religious bodies, led to just a very small proportion of facilities administering the vaccine through school outreaches, and even lower proportion of school administrators admitting the fact that vaccination was done in the schools. And to wrap it all up, there was limited advocacy around the vaccine. In fact, only 24% of the facilities we sampled in the introduction assessment actually admitted to receiving communication materials regarding HPV. And as you can see, all 100% of facilities sampled mentioned communication as a major challenge. This just goes a long way to highlight the considerable amount of HPV vaccine hesitancy that exists in Cameroon across all the levels of the healthcare system pyramid, and even with the key stakeholders. So out of this assessment, we had 3 main recommendations. Firstly, map stakeholders involved in HPV related activities, engage them, and also explore avenues to link whatever it is they're doing with HPV vaccination. Next was to reignite and reinvigorate technical working groups at different levels of the healthcare pyramid in order to make sure that meeting activities and meeting recommendations were implemented. And lastly, it was to communicate properly around the vaccine and ensure that plans from the central level and the regional levels reach right down at the level of the implementation levels. So if we focus on the first recommendation,
Clarence, can I just ask you to wrap up in the next 2 or 3 minutes, please? Thank you very much.
Exactly. Okay, that'd be great. So if we focus on the first recommendation was to map and engage. So CHA went ahead to support the EPI in Q3 of 2020 to kind of identify adolescent and youth services with which a potential integration with HPV vaccination could be done to boost coverage. And to achieve this, we used the 4-pronged process like outlined below. And at the end of the day, the interventions we identified through this mapping were prioritized following a scoring system we developed that assessed both the feasibility and the potential impact of HPV integration with the concerned program. So at the end of the day, about 21 projects interventions were identified. 8 of them were prioritized, and the top priority was that of the school health program. So as way forward, what CHA is currently doing is to collaborate closely with the EPI to actually test that integration approach for HPV vaccination within schools. And so the plan here is to assess the acceptability and feasibility of delivering the vaccine in a one-dose schedule and a gender-neutral manner. Like we just mentioned, that's the trend towards which we're going in Cameroon. And also to explore ways in which we could optimize the delivery of the vaccine in facilities through systematic screening. So in addition to that, we also want to make sure that we outline all the operational details that are needed for successful integration. And it's what highlighting that Chris actually has an article that was published recently that clearly outlines the importance of stating those details so that they could be used alongside what is known on vaccine service delivery to choose strategies that are best suitable for delivery of the HPV vaccine. So in all, we are actually quite hopeful that results and learnings from this pilot will provide us with the insight we need to revise and update vaccination strategies against HPV in Cameroon and, in essence, help us to achieve a high coverage for HPV vaccination. And thank you so much for your time. It's been a pleasure.